today's session. My name is Dr. Washira, and I work for Equalize Health. I welcome you all to the third session of COG's tele-monitoring session on strengthening obstetrics and gynecological care for maternity teams. So today's topic is obstetric hemorrhage, and Equalize Health has partnered with COGS to bring these online sessions. And since 2018, we have implemented several telemonitoring programs for health professionals in India and in Africa. So our programs work with the principle of the Project ECHO by the University of New Mexico. So before we start, I'd like to just make some announcements, some housekeeping announcements. Please keep your mics muted unless you're talking to avoid distracting the person on making the session. And then if possible, kindly put your videos on. Also, we'd like you to respond to questions without any hesitation. This is a very judgment-free zone, and every case discussion can be treated as an example to learn and to share. So also you can post your questions in the chat box. And I'd like to welcome Dr. Kigunda Kagondu, to introduce our speaker for today.
So without much further ado, I would like to welcome Dr. Christine Murungi, the consultant gynecologist, and she's the head of gyne at Outpatient Teaching and Referral Hospital. She completed her University of Nairobi undergraduate studies of MBCHB and obstetrics and gynecology M.Med studies at the Aga Khan University. She has previously worked as an instructor in Obs Gyne at Aga Khan University Hospital, Nairobi, and she has also been the head of department at Chogoria Mission Hospital. She's a faculty member at Kabarak University, Family Medicine Program and Institute of Family Medicine, and Advanced Life Support in Obstetrics. She serves as in our Kenya Obstetrics and Gynae Society Central Branch, and also laparoscopy machinani. So without much further ado, I would like to welcome Chris through obstetric hemorrhage. You know, obstetric hemorrhage is the leading cause of maternal morbidity and mortality. And she has a bit of expertise in that, having delivered 3 energetic boys normally. I think she has the moral authority to talk to us about obstetric hemorrhage and its management. Welcome, Christine.
Ma'am, you're on mute. Dr. Christine? Yeah.
All right. Are we good now?
Yes, yes, ma'am.
Okay. All right. Thanks, Kigondi, for that introduction. Clearly, you had to bring in the thing about normal delivery, but thank you very much for that intro. So, good evening to everybody. I'm glad that you could all make it for these very exciting sessions, which I think, at the end of the day, it's to try and ensure that we find a way to provide the information to allow you guys to practice up-to-date obstetrics. And we really hope that these sessions will be able to empower you, most of all, to be confident about the decisions you're making and the management that you're putting across. So at this point, I'd like to share my screen. Let me do that. Okay. Can you guys hear me? I'm seeing a message that I'm not audible to everybody.
I can hear you.
Okay. All right, let me share my screen. Sorry. Okay, we're good. You can see my screen, okay?
No, we cannot see your screen, Dr. Christine.
No? Okay. Let me give that another try. Okay. So it's telling me there's an error code. Let me try again sharing it. Can you see?
No.
Not yet.
So unshare, then share again. Unshare, then share again. And then click on the open the document, open it, and then unshare, then share.
Yeah.
Okay, the document is open. So let me try and share again. Okay, so here we go. Are you seeing it? No.
No.
All right. It's okay. Let me just give me a minute.
Yeah. Ma'am, are you able to see the share screen button on the Zoom?
Yeah, at the bottom, right?
Right. And when you click on that, are you are you selecting the first option which comes as screen?
Okay. For some reason, it's saying screen sharing has failed to start. Please try again later.
Okay. If you can try once again, otherwise probably you can just try and share your PPT so that one of us can share from our side.
Okay. Okay. So someone can. Okay, fine. Let me try one more time. I know last time this worked out so easily. I don't know why it's causing an issue today. All right, let's see. Advanced okay. Okay, screen. Yeah, for some reason it doesn't want to share. Let me just forward it.
Yeah.
Yeah, just 1 second.
You can either send it to Joki.
All right. Okay, 1 sec. Sorry about this. This should have been easier than this.
No problem, ma'am.
Guys, take a sip of water, or just grab something quick to eat before I start. I just attach this file.
No, that's problem. That happened to me on Monday, so it's nothing unusual. It happened to me on Monday. Yeah.
Yeah, that's fine. Sorry, I'd hoped to be here a bit earlier, but work issues got me kind of stuck. But let me see. Okay, so I can attach here. Gmail.com. Okay. All right, just finishing attaching. So Simon, how did you resolve it on Monday?
It got resolved automatically. So he was able to present.
He was able to present.
Yeah, you unshare, then share.
Okay, okay.
Just send as you are trying so that we project for you.
So I've sent back to the Equalize Health, and Simon, I've sent it to you as well.
Okay.
In the meantime, I'll try again. So let's go here. Thank you. Got it?
Not yet, ma'am. Joki is waiting.
I'm also seeing my Zoom is misbehaving. It's not allowing me to, okay, can you see it? All right, let me try again.
Hey, Dr. Christine, where are you sending it?
So the email that had sent me the link, as well as Simon's email.
Right.
I'm looking
Can you
at
see it? Has
Okay.
it come?
So thanks, Dr. Simon.
now we can see it.
Yes.
Yeah.
Can see it? Oh, Simon has it.
Yeah.
Okay.
Yes, ma'am. Thanks, Dr. Simon. Ma'am, we can start.
Okay, cool. So fine. So sorry, guys, once again, welcome to today's topic on obstetric hemorrhage. And basically how I'm going to tackle this topic is mainly in two parts, because we categorize obstetric hemorrhage as the antepartum hemorrhage and postpartum hemorrhage. And through both, I'll take you through the causes, clinical evaluation, management, and we will have a brief case and then a summary. Okay. So as a way of introduction, we all know that maternal mortality is unacceptably high, and more so in the sub-Saharan African region. And as I've mentioned, the majority of the maternal deaths are in the low resource settings. That's up to 94%. That includes us, basically. If you look at the figures from WHO in 2017, 810 women would die per day, which means as we start this presentation, within the next 1 hour, 34 women will have died within that time. So when we look at maternal mortality, the major cause is hemorrhage. It's number one, which is why we are emphasizing so much on the need to know how to recognize and manage obstetric hemorrhage. Well, with that said, it's still important to recognize that there are other risks and there are other causes of maternal mortality, including infection, hypertension, other complications from delivery, and unsafe abortion. So our aim with doing this training is to ensure that you provide skilled care before, during, and after childbirth, which then saves a lot of women as well as their newborns. So next. All right, so what is it? I mean, why is obstetric hemorrhage such an issue? This is because there's a whole variety of morbidity that's associated with it, right from the fetus to the mother, issues of prematurity, low ABGAS scores, and what that means long-term for this child. They're also associated with a higher C-section delivery rate and whatever else comes with C-sections. These women are at a higher risk of having hysterectomies, and as you know, with that, then you end their childbearing careers. Other issues of transfusion, and in this country, remember how tough it is, especially in some regions, to get even whatever blood products that you require. Ultimately, yeah, death, the mother, the fetus, and let us not forget that there's also a social impact. This is a woman who's in hospital for a prolonged period in time. There are financial issues, paying bills, etc. And maybe some of you have come across this. Some women actually do get post-traumatic stress disorder from an event that involved postpartum hemorrhage. So as we go through this topic and as you manage patients, go back. I'd want you to remember these things. When you see a woman bleeding in late pregnancy, ask yourself, what is the likely cause? After that, ask yourself, is this amount of bleeding or the likely cause life-threatening to either the mother or the fetus? And then you ask yourself, what are the next steps in diagnosis and management? All right. So always remember those three key things. Next. All right, so let's just dive right into it. What is antepartum hemorrhage? This is bleeding in the late pregnancy. So we are focusing on third trimester bleeding. There are other topics to do with first trimester bleeding, early pregnancy bleeding, but we're focusing on late pregnancy bleeding above 28 weeks. Now, it's important to concentrate on the first three that I've highlighted, because a majority of the time, those will be the cause of your postpartum hemorrhage. That includes placenta previa, abruptio, and uterine rupture. And now that's even more of an issue because C-sections are being done quite often, and that puts them at risk. But remember, there could be other causes, including local causes. Next. Good. So tackling placenta previa, I mean, most of you have heard of it, have come across it, but just to refine your knowledge about it, remember this means a placenta that's close to or overlying the cervical os. Okay, you may pick a low-lying placenta in your maybe anomaly scan at 20 weeks, but that doesn't qualify as placenta previa. You need to repeat this scan at 34 weeks and above when the lower segment is formed, and you can accurately classify it as a low-lying placenta, a placenta previa or not. Okay, as you can see on the diagrams on the right side, you can have what we call a marginal placenta previa, where the placenta is within 2 centimeters of the cervical os. Some people call that a partial previa, or you can have a complete previa, which covers the os. Okay. Now, before a patient is, term or ready to be delivered, there's outpatient counseling, especially for low-lying placentas. This is important because you will come across low-lying placentas. The general counseling is about them avoiding any triggers, like avoiding intercourse, and you need to be sure that they have access to hospital. Meaning, if your patient lives very far in the interior, you need to discuss with them the option of moving closer to the hospital. Some hospitals even have a unit within that is called an antenatal hostel, meaning that a woman can be accommodated within the hospital, not like a true inpatient who requires the full level of care, but a patient who's within hospital in case of any hemorrhage. Okay, and it's important to talk to them about their risk of preterm delivery and their ultimate risk of hemorrhage, because at any time they can go into torrential bleeding. Okay, next. So with regards to risk factors, it's important to recognize them. But I wouldn't want you to focus too much on that, because sometimes you find a woman with no risk factor, and you then do a scan and find she has placenta previa. But risk factors help us to immediately start thinking ahead. When you get a mother who's got a previous history of placenta previa coming in, bleeding again, your mind is thinking more towards placenta previa. But remember, it can happen with someone without a risk factor. What I want you to focus more on is the presentation. So a patient comes to you late pregnancy and she has this, painless bleeding, tells you woke up from bleeding, which can be of any quantity. Could initially start off with some spotting and then build up to heavy bleeding with clots. The initial bleeding may be light. This is what we call a sentinel bleed. And remember, as the pregnancy progresses, the placental mass increases and the blood flow to the uterus increases. Subsequently, the hemorrhage can be so much more, okay? So which is why most of the time we prefer to have them admitted. You may find a fetus the presenting part being high or an abnormal lie, like a transverse or a breech, because the fetus is then unable to engage. Those are just, add to the baby. Next. So that is Previa, and it's, can I call it the sister? Because anytime you have late pregnancy bleeding, you're always debating, is it a Previa, is it an abruptio? Now, an abruptio by definition is a premature separation of the placenta. And of note, which is so important, is that this, you may see it as a revealed bleeding, or it could also be concealed. Meaning the patient bleeds behind the placenta, but it does not trickle down for you to see it, okay? So always be cautious about this kind of patients. Then again, also risk factors do exist. One main risk factor I'd like to point out is hypertensive disease and previous abruption. These are patients who we've commonly seen coming back with an abruption, but any sudden decompression, like a patient who's had prom, especially those with polyhydramnios, that can happen. Trauma, patient who's been in a road traffic accident, why we actually admit to monitor is there could be that risk of an abruption because of that acute impact. All right, great. Moving on. So as a pictorial presentation, I want you to look on the right side of your screen. You can clearly see now the difference between a revealed hemorrhage, which is picture A, versus a concealed hemorrhage, which is picture B, okay? But ultimately, they will present in a similar way, other than the bit about whether it's revealed or not. And these patients have more bleeding and pain association, as opposed to patients who have patients may also present with a bloody amniotic fluid. For example, you do an ARM intrapartum, you find blood-stained amniotic fluid. In my practice, I've had a patient who had actually come for an elective section between the spinal and all the positioning, etc. Did the C-section, this blood-stained amniotic fluid. Then the fetus needed resuscitation, but that is one of the signs. Patients can also present with contractions. Blood irritates the myometrium and therefore can cause contractions. And sometimes it can be very hypertonic, meaning they appear as though they are hyperstimulated, so multiple contractions, yeah? We can also have maternal compromise. And this is very important because you may find a patient with a concealed hemorrhage, there's no blood showing, or a patient with a revealed, there's minimal blood, but the hemodynamics are out of proportion to what you're seeing. And that is because the hemorrhage are not seeing everything. So maternal compromise is very important. So all vitals in labor ward, on admission with any bleeding becomes very crucial. Subsequently, you disrupt the blood flow around the placenta, you get fetal compromise, which can be severe enough to cause an IUFD. Next. Good, so those are the first two, Previa, abruption. Now let's come to the third one, which is uterine rupture. As I mentioned, we're doing more and more C-sections, and that becomes one of the main risk factors for uterine rupture. Uterine ruptures can be, someone who keeps saying I can't hear. I hope everybody else can hear. Okay. So
we are audible, Christine. I think it's the device. Continue.
On their side. Okay, great. So when you look at the risk factors, I mentioned C-section is a very critical risk factor to bear in mind. I recall not too long ago, about 2 months back, a patient presented in our facility after having 3 previous scars, unfortunately ruptured in her 3rd scar, and now was coming with her 4th pregnancy at 32 weeks and severe low abdominal pain. And believe it or not, she was rupturing again. So a history of a rupture is also another significant risk factor for these patients. And it's important to bear that in mind. So hyperstimulation, why I'll mention that is because we're augmenting patients in our labor wards very often. And if you're not careful about how you're doing the augmentation and titrating it against the number of contractions, you just need to get your adequate contractions, 3 to 4 in every 10 minutes. Beyond that, you run the risk of hyperstimulating. Misoprostol is also another culprit, especially in the grand multiparous women. Great. So how do you then recognize uterine rupture? There are key features, and one of the most early features you can get is an undersharing fetal status. Commonly, you get a bit of a tachycardia, then you get what we call decelerations, which means you have irregular heart rates dropping down. By the time you're getting bradycardias, it's usually more of a terminal event. So patients who are also in labor, when suddenly the contractions just die off and you can't explain, sudden loss of your station, more severe pain, PV bleeding, hemodynamic instability, those are all things that should make you think about uterine rupture. Okay, next. So now, knowing all that, how should we then manage these patients? What I want you to remember is anytime you have a patient with obstetric hemorrhage, in as much as I've talked about the different causes, ultimately they fall under one line of management. What do you do? She's bleeding in her 3rd trimester. You quickly take her history. What gestational age are we dealing with? Because one, of course, you want to know whether it's a late pregnancy bleeding. Next thing, you want to characterize the bleeding. Is it minimal? Is it moderate? Is it in clots? Is it just spotting? Because that'll help you risk stratify. Is there presence or absence of pain? Were there risk factors or any precipitating factors? Are they in labor? Is there a previous scar? Okay, so a quick one, yeah? This is not the time you start going so much into extras in your social history, where do you live, etc. It's a very targeted history. And then your examination, there's no shortcut about this because your vitals are so crucial because they'll tell you where you're starting. Are you starting with a patient who's hemodynamically compromised? Is she stable for now? When you do your vitals in another half an hour, the vitals are worsening. So it really helps you gauge your situation. A quick abdominal exam, is there tenderness? Are there contractions? You do the obstetric exam, you check the fetal heart rate, okay? Now, the next thing is key, speculum. A lot of people run away from doing a speculum. Don't move. Back to the slide. So speculum exam, it's very key because you must be able to look at the bleeding. Is it from the os? And there could also be other local causes. So as a gentle speculum exam is critical, and do not, and I repeat, do not do any digital exam in a patient who's bleeding, as tempting as that might be, okay? Moving on, next. So once you've done that quick history and examination, the next thing is your plan of action. What must you do then? IV access, always do not underestimate the bleeding. Even if it's spotting, she's in 3rd trimester, IV access, because next thing you know, it could be a river, right? Green or gray cannula, gauge 16 or 18. Basically, like in our labor ward, what we've done, I've confiscated all pink cannulas, yellow, blues, because you'll find people using them, yeah? And the thing is, when you really need fluids to flow, those cannulas do not help. So just commit to green, gray cannulas, okay, irrespective of the quantity, resuscitation of fluids guided by your hemodynamic status and the amount of blood loss. Group and cross-match always, because you don't start chasing blood when you eventually see things are fake. Get your blood on standby early. You must admit and monitor because you don't know how that could go. Now, because of their risk of delivery, you give steroids. Bleeding could settle and you have time to buy, or bleeding may not settle and you need to deliver, okay? And of course, those who are under 32 weeks, magnesium sulfate. Your consultant must be involved because there's some tiny little details that you need to work together with the consultant to basically chart the way forward. Don't forget that any patient who's rhesus negative, this is a sensitizing event and they need the anti-D. If you're not equipped to handle, you do your part, put the IV access, start fluids and transfer out, because the more you sit on it, the more you get into a tough scenario. Lab works that you'll run for include your full hemogram, see what kind of HB are you starting off with, cross-match. Imaging becomes crucial because you want to confirm, do we have a placenta previa or an abruption? Let me just tell you something small about abruption. Ultrasound is not very good at ruling it out, because if you don't see an abruption, doesn't mean you do not have an abruption. But if you do see it, then yes, you do have an abruption. Okay, good. But the critical bit about the ultrasound, it will tell you, is it a previa or not? And also it will help you gauge your estimated fetal weight, the gestational age. All right, good. If you have access, you can do the coagulation profiles, you will see. But the full hemogram, GXM, and ultrasound are most important. All right, next. Next. Good. So with that said, like you've done your initial acute management, basically there's some considerations which I won't dive so much into because at this point, you're going to manage the patient as a team. And with the previous, basically with previous, you need to consider when are we going to deliver this baby? Is it a complete previa where the risk of hemorrhage is higher? Is it a partial? When these patients go for C-sections, the risk of hysterectomy is high, and we usually have that in the consent, and even the risk of placenta accreta, etc., is also high. Patients who have abruption, remember, it's not all abruptions that are due for C-section or delivery then. There's room for conservative management if it was just a minimal bleeding and the fetal status is fine. The other thing you need to remember about patients who have abruptio is the more they bleed, the more you end up with consumptive coagulopathy. So don't also delay management when you see things are not okay. Uterine rupture, there's just one way out. It's an emergency laparotomy. All right, great. So moving on. The reason why I put this slide is just to let you know that whenever you have bleeding, it's not just Previa and abruptio or rupture, but remember sometimes it's a simple polyp that is problematic. We've seen several of those polyps, or it's a patient who unfortunately has CA cervix and it's symptomatic during pregnancy. So once again, speculum is key, all right? Okay, let's move to the next slide. All right, so let me wrap it up with the antenatal bleeding, the antepartum hemorrhage at that point. Let's move to postpartum hemorrhage. Now, I think PPH is even a greater issue, and you cannot work in an obstetric unit if you're not conversant with postpartum hemorrhage. As much as possible, run routines in your unit, and postpartum hemorrhage should be woken up at midnight, and you have a good idea of how to go about it. Okay, so by definition, this is the bleeding that is present in the first 24 hours after delivery. And as a note is that when you actively manage your third stage of labor, it truly reduces your incidence of postpartum hemorrhage. And this has been validated by trials, etc. So it is very key, and it should be just part and parcel of your labor ward practice. Monitoring fourth stage is important. Some units I know get overwhelmed, but remember that fourth stage is your window to ensuring you pick postpartum hemorrhage. Yeah? I worked once in a very busy unit where the nurses would just tell the women, just make sure you're breastfeeding, you're rubbing the uterus, so they are doing the massage, uterine massage themselves, and to some degree that also helps. But remember your vital examination, the 2 hours post-delivery critically are important. Then empowering your woman to voice when their lochia loss is more than, instead of getting less, it's increasing. Okay. Now, the next point is so important. I cannot overemphasize that. Remember that postpartum hemorrhage is not always predictable. Okay. All women who are giving birth are at risk, and it's the #1 cause of maternal mortality. We commonly underestimate our blood loss. Okay. Many times, you go in and ask how much blood loss, you hear maybe 100, 150, but then, you look at the sheets are soaked and you see, her clothing is soaked. There's some gauzes that have, cleaned up the vaginal area. So it cannot be that 150. So remember, we also underestimate. Let's strive to try and estimate correctly. Yeah? Now, risk factors are important to note. The reason why I think, personally in my practice, I've noticed, I've recognized risk factors is because they allow you to also put in prophylaxis for those you deem at high risk, okay? That still means all are at risk, but at least these ones who are at a higher risk, you can always give prophylaxis. For example, run a drip of oxytocin after delivery, or give prophylactic doses of misoprostol after their delivery, okay? So those include patients with previous similar history of PPH, the grand multiparas, patients who have twins, prolonged labor, preeclampsia, instrumental deliveries. Those are generally patients who are at risk, okay, over and above just being a woman who's delivering. All right, next. Great. So mnemonics are always useful because in obstetric practice, we don't want you to cram so much, but if you have a mnemonic, which is an easier way to remember, then you're able to run through your differentials easily. So we call these the 4 T's of postpartum hemorrhage, which are tone. Tone signifies atony. This is where the uterus fails to contract well, and that covers 70% of your postpartum hemorrhage causes. What that means is your initial efforts will be geared towards sorting out your tone, okay? Secondly is trauma. Think about it this way. Every time after delivery, there's either, a 1st degree, 2nd degree tear, or there's an episiotomy. So it commonly comes in 2nd as a cause. There are other less common causes like hematomas. Then tissues comes in 3rd, and this is either the placenta as a whole or in bits and pieces, or it's an invasive placenta. And then lastly is thrombin. Not very common, and I think that's a blessing because it's a headache to manage, where a patient is no longer coagulating, and you can easily lose your patient when you reach there. Okay, so with that said, your principles of management for any postpartum hemorrhage should be, you always call for help, just like any other obstetric emergency. Whether you have a shoulder dystocia, you call for help first, yeah, because you do need a team to manage. So as I mentioned, your initial efforts will be geared to address tone. So in as much as you see a tear, yes, but you must address your tone because your tone can compound your tear, all right? Then lastly is every unit must endeavor to have a Pph box or a trolley. This can be anything simple. You can have an emergency trolley, the commercial ones, or you can even have an old suitcase converted into a Pph trolley. What's important is the contents, okay? Then you must have a protocol in your unit. For quick reference, units have high turnovers sometimes. You find maybe in the nursing care or the clinicians, the MOs, the turnover is high. So it's good to have a reference unit whereby you can say, okay, I know I need to give Oxytocin. How much was it again? You just quickly reference and you ask yourself, have I left something out? Quickly reference, okay? Next. Good. So how then do we manage postpartum hemorrhage? Can I just point out that if you have Pph, don't say it's a half Pph, so I'll do half the efforts. When you have Pph, Pph is Pph. So you manage the full Pph, okay? So you can look at that flow chart. You initially start by actively managing your third stage of labor, which I know most of you recall is giving the oxytocin 10 units IM, control contraction, and the uterine massage, okay? As a way of quantifying and deciding are you in Pph or not, any blood loss through vaginal delivery more than 500 ml is considered Pph, C-section more than 1,000 ml. But remember, any amount that causes hemodynamic instability will be classified as Pph. You can get a woman coming in to deliver with a HB of 9 versus a woman with a HB of 14. Each lose 500 ml, but the one with a HB of 9 will exhibit symptoms of Pph other than the one who has a better HB, okay? So you then manage appropriately. As I mentioned, call for help. Do the bimanual uterine massage. I've put a diagram there so that we understand what that is, because there's just the uterine massage, which is on the abdomen, just rubbing the uterus on the abdomen. But when you're doing a bimanual compression and massage, your whole fist of your right hand goes in. I think one, two, if you have a big hand. And I think labor wards, guys who have small hands are kind of known, so we sometimes just ask the one with the smaller hand to go in. But if you're the one who is there, we say fimboya mbali hayui nyoka. So if you're close, you do it, go for it. This diagram should help you remember. So you're trying to compress the anterior and posterior wall of the uterus, as you can see on that diagram, okay? And you compress and massage. This also helps you buy time before the rest of the team arrives, or if things are so bad, before someone more senior arrives. Next. Good. So then once you've started that, what do? You have a team, you call for help. What are people's roles? So you who's down there, normally the person who's, can I call it team leader at that time? And team leader can be anybody. It can be the nurse who's there, the clinical officer, the MO, but whoever starts the drill is down there in the perineum. So that is sort of your team leader, and then calls out to the assistants, assistant A, insert a wide bore cannula, assistant B, insert another wide bore cannula. Someone is monitoring the vitals to see where we are, and they need to say it out loud and say, BP currently is 90/40, heart rate of 120, patient is drowsy. So you know where you are, right? As opposed to a patient who has normal vitals. When you insert the wide bore cannula, quickly take samples for lab works. And on the other side, someone is starting off IV fluids. Once you've quickly taken out your blood works, you start a drip of oxytocin. Remember, your efforts are geared towards improving the tone. So oxytocin 20 international units in 500 ml, run it fast, and then a similar concentration to now run a bit slower, all right? Next, you give your tranexamic acid. Tranexamic acid, without a doubt, is important in postpartum hemorrhage management, backed up also by a lot of scientific data, lots of RCTs. But this is most effective when given in the first 3 hours, okay? So it's part of your initial action. Misoprostol, 800 to 1,000 micrograms. You can give it per rectal, sublingual, per oral, just depends. If your patient is semi-conscious, then of course per rectal is more appropriate. Of course, you cannot give it per vaginal because she's bleeding. Remember, the sublingual route has a faster uptake of the medication, so they feel the shivers, the fever, they can also get diarrhea. They generally have more side effects with the sublingual, but it goes in pretty fast. You can choose to split your dose and give part of it sublingual for quick action, and then you give it partly per rectal. Those are all fine. Egometrin, if it's still available in your unit, some units discarded, but some units still have it. It's also very important. Just ensure your patient is not a hypertensive. Carboprost, a little more costly, but available in some units. And that is also a prostaglandin analog, which can also help you to achieve good uterine contraction. Now, once you've done all those efforts geared towards tone, you need to think through the 4 T's. I've sorted out tone, and you keep assessing. Is the uterus well contracted or not? Then you assess for tears. Some tears are bad, like you may see on the vulval area, there's no tear, but when you assess on the inside, you find a vaginal tear or a cervical tear. So good positioning, good lighting should allow you to do a quick assessment, okay? Then what else? Yeah, so your tears, and then you check the placenta, ask your assistant, check the completeness of your placenta, and then lastly is your blood clotting. Sometimes you will see a trickle and the blood looks like colored water, meaning it's not clotting, it's not thickening up, and you know you're in trouble at that time in terms of coagulation. Okay. But if with all those efforts, your bleeding is not settling down, then you need to go in and do an examination under anesthesia and consent for a laparotomy, which may include up to a hysterectomy, okay? From there on, at least your consultant or someone more senior should be available. We've used Bill-Lynch sutures very effectively in the past, which have prevented us from having to go all the way to hysterectomy. The balloon tamponade is very useful, even just general maternity wards or sometimes even in theater. Okay, good. Next. So I just wanted to illustrate the balloon tamponade. Personally, I've used it quite a bit, especially when I was working in the mission. Patients who are, especially those with rare blood groups, and you find they are bleeding, and you won't have quick access to blood. This has saved us many times, because ultimately what you want to do, go and have something compress the uterine side walls and the bleeding channels, and therefore you have less blood loss. You keep it in for about 24 to 48 hours, after which you can start deflating and check whether you're okay. So picture A is a picture of the commercial Bakri balloons, but picture B is the modified one. Okay, this looks more, it's a modified one where you use a condom and a Foley's catheter, basically, and then there's a way you do it. It might be beyond the scope of a PowerPoint presentation. This, you really need to see it, how we assemble it physically, but just to let you know there's that option, and you can always look it up or have someone to show you how to do it. Very useful. All right, next. So once you're done managing, you've settled the patient, however far you had to go, then what do you need to do? You sit down and indicate what happened. She started bleeding, she went into PPH after delivery, which was at 9 p.m. Noticed PPH at 9:30. Did all those things you needed to do. And so the timings are critical. Then you need to put in, what did you find? Were there tears? Was there an issue with the tone, etc.? What was your approximate blood loss? And basically what you did. And then what is the plan? Plan includes, are you running a drip of oxytocin for the next 4 hours? Monitoring of local loss. All those points are very critical, so don't leave it open and assume everybody knows what to do. Just have it documented. Your urine, because you should have put in a catheter, okay, for the purposes of urine output monitoring, as well as keeping your bladder deflated, hence allowing for the tone to maintain of the uterus, okay? That is part of the plan. So blood, are you planning on transfusing? How many units are you aiming for, etc. So any antibiotics you need to give, especially if you did a lot of manipulation, you need to give prophylactic antibiotics, okay? It's also important to debrief the patient. Sometimes the patient may not understand everything at that time, so you need to have that wisdom of what to tell the patient at that time. It might be something simple like you bled a lot, we need to give you blood and we're going to monitor you. But there could be a spouse out there, you need to take them through what happened and what the plan is. Yeah, basically. All right, next. So let's quickly go through a case of which I hope through the presentation you should be able to at least give me some answers to. And this case is of a 35-year-old, gravida 6, para 5 plus 0, admitted in active phase of labor at 39 weeks. She's had previous uneventful vaginal deliveries with no comorbids or surgical procedures. She developed slow progress during her labor due to poor contractions and required augmentation. She then progressed and got to second stage, which was prolonged and required a vacuum-assisted vaginal delivery. She delivered a live male infant, a score of 789 with a birth weight of 4 kilos. All right. Now, in that history I presented there, I'm sure we can see a few risk factors for postpartum hemorrhage. Maybe as the team, feel free to just, point out any risk factor that you see.
I think for 30 seconds, they can type in the chat, then we read out.
Okay, yeah, cool. Bernard Owino, I can see multiparity. Kasade, Kevin, high parity, yes. Okay, I think delayed second stage, yes. Any other? Yeah, age, this 35 as a cutoff. Yeah, okay. Prolonged second stage, very good. Augmentation, big baby, well done. Assisted vaginal, yeah. Macrosomia, big baby, yes, I can see. Excellent. Yeah, I think we're all saying the same thing, okay? Yeah, we're saying she had a slow progression. Remember, any augmentation, prolonged labor, prolonged second stage, vacuum delivery, and a large baby. So excellent. Good job, guys. This one, I think everyone should be able to type in like in 2 seconds. What's the most common cause of postpartum hemorrhage? Go for it. Okay. Yes, yes. Awesome. Good, good stuff. I think guys know that one. Attorney, excellent. All right, good. So the patient went on to develop Pph, yes, due to atony, and the team did the following. They rightfully called for help. Someone went in, did the evacuation of clots, did a bimanual uterine compression, inserted a catheter, Foley's catheter, put up an Oxytocin drip, and began fluid resuscitation with normal saline. However, the uterus was still atonic. What else can this team do to address the issue of atony? Yeah, feel free to type, at least I can see answers when you type. So other than what they've done there, what else can they do to address atony? Okay, balloon tamponade. Before you go there, because remember it takes some time to misoprostol, excellent. Yes, Synto has been given. Tranexamic, excellent. Empty bladder, okay, has been said. UBT, okay. Egometrin, yes, I'll take that, good. All right, Tranexamic, yes, 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 yes. Okay, and yes, condom, okay, good, good, okay, excellent. Fine, so, and carboprost, don't forget, eh? Good, so what item should then be stocked in your Pph trolley? You've seen how we should manage Pph. What do you think should be at hand when you need to manage Pph? And therefore, when you go back to your unit, you're going to develop a Pph trolley content. Foley's, yes, I've seen someone put Foley's catheter. What else? Misoprostol, good. IV lines, yes. IV fluids, cannula, yes. Granulas, okay, tranexamic, large bore. Very good. I like that who said large bore. Don't just put any. Good. IV fluid specific, I saw ringers, lactate, normal saline, very important. UBT, yes, you should have your kit there, at least a set of 2, or to assemble, staff to be able to assemble 2. Excellent, good. So let me say sometimes misoprostol, I can see coming up. Misoprostol sometimes brings issues in units, just because we have a lot of training schools, and people are always suspicious of guys picking misoprostol for other indications. So if your unit has challenges with that, and your pharmacy has 24-hour access, you can still maintain it in your pharmacy, or it can be the DDA, where the key is under control. So here is an example of what we have in our Pph Trolley Content. The cannulas, the needles for withdrawing, syringes, it breaks down to that simple, as in you have to get down to the simple things as I need a needle, I need a syringe, okay? So not just the big things, yes, the giving sets, including that for fluids and for blood, so that when you have PPH, it's midnight or 2 a.m., you don't have to go looking for stocks in the pharmacy. Speculums for examination, VPACs, medication Tranexamic. I've put magnesium sulfate just because it also serves for patients who have preeclampsia, eclampsia. Okay, so this box can be an emergency trolley content box or trolley in the labor ward. This trolley or box should be checked regularly, meaning this list is put next to the box, and every day there should be a rota for checking in the morning when nurses go in to do their morning handover. They should be a tick in case anything was used, it needs to be restocked. Okay, great. Next. Next. Good. So in summary, what are we saying? I'm truly just emphasizing hemorrhage is the #1 cause of maternal mortality. Master this and you become a gem to your patient because you're able to manage them well. And as a unit, you can care for these patients. So always be prepared. That involves also training, like what we are doing today. It involves running drills within your unit. A drill or a skill session just involves, half an hour of, where today we're doing PPA. And what are you going through? Simple things like these are the causes. You don't have to go to fine details. It shouldn't be so academic, but you just focus on the clinical management, how to recognize, how to manage, what should be stocked in our PPE. Then the other thing is just reminding you that a rapid clinical diagnosis and early intervention is crucial. Always ask yourself, what am I likely to deal with? Is it life-threatening to the fetus, the mother, or both? What really should I be going, what should really be my next steps in making this diagnosis more specific, and how should I go about managing? PPH being the most common cause of hemorrhage, you should always remember your 40s, with the top on the list being tone, okay? So that you always address tone as you look for other causes. All right, good. Next. So those are some of my references. Next. And with that, I come to the end of my presentation.
Thank you very much, Christine. And I think you've done very well. That will be very useful in helping us. So we'll go quickly to the questions. Maybe you can scroll a bit.
Okay.
Are there any questions there? Karen Cherono asks, in cases where the mother is showing signs of shock, there is need to apply non-pneumatic anti-shock garment if available. Maybe you can comment on that.
Yeah, I mean, like, how many of you have that accessible? If you do have, remember when you apply that, you're trying to keep the blood to the critical organs, the brain, the heart, right? So if you do have, well and good. Do not waste time trying to, source for them, look for them. There's something maybe I should mention that it's called the aortic compression. I don't know if any of you have had to use it or are aware of it, the abdominal aortic compression. That is something that is easy for you to do without any gadgets. And you're able to look at a video on how to do it or have someone show you how to do it. It's also another way of reducing blood flow to the uterus, maintaining blood flow to the critical organs, and it just requires you around the umbilicus area to slide slightly to the patient's left and compress the abdominal aorta. Even intra-op, you can do it by actually going and feeling for the aorta and compressing it. It reduces your blood flow, maintains blood to the critical organs as you wait for maybe fluids to run or blood to run. Yeah, anti-pneumatic stockings not widely available, but if you have it, fair enough.
There's a question on magnesium sulfate. In this case, would be for neuroprotection, that someone was asking whether it can be given in less than 32 weeks.
Yes, so true. Magnesium sulfate has been found to be critical for neuroprotection of the fetus. And well, let me say, no one truly knows exactly what gestation, but we've all adopted less than 32 weeks and below seems to be the optimal gestation we should give. We should aim to give the mothers who are at risk of preterm delivery. The way we give it is similar to patients who have seizure prophylaxis or in patients with preeclampsia.
Harriet Bonareri is asking, when managing PPH, do you administer oxytocin, misoprostol, and tranexamic at the same time, or what should be done?
Good question. Yes, please do, because they all have different onset of action timings and different modalities of action. Oxytocin, the oxytocin receptors, and when you give it IV, it's immediate, okay? And then has a short half-life. When you look at misoprostol, that's prostaglandin, so it takes some time for us to reach peak plasma concentration, and tranexamic acid is an antifibrinolytic, so a different mode of action. So yes, go ahead, give them at the same time.
Comment on the use of carbetocin in prevention of PPH based on the findings of the Champion trial. That is Samuel Gatei.
So carbetocin is heat stable with syntocinon. And the thing about it is the trials found that it's non-inferior to oxytocin, right? So it is a good alternative. There are cost issues and availability, but yes, used in active management of third stage of labor has a similar effect to what we generally use as oxytocin. Remember, the reason why we have tried so hard to look for an alternative is the issue of refrigeration. So yes, it's non-inferior to oxytocin and useful.
What George Work is asking, what is the rationale of having the volume of saline as you administer oxytocin, yet volume replacement is also important in PPH? A good question.
Just repeat that again.
So in essence, what is the rationale of halving the volume of normal saline as you administer oxytocin, yet the volume replacement is also important in PPH?
Okay.
He's generally asking, as you're giving PPH, why do you want to decrease the normal saline, yet you have lost fluids and you need the fluids?
Okay, good question. So please remember this, you are trying to get in oxytocin as an infusion, not as a neat push, okay? So you are putting that in a volume of oxytocin, in a volume of saline, which will then run slowly. But on the other hand, you have another drip that's running fluids that is just, running into for volume replacement, okay? So it's not, let me say the volume running with oxytocin, yes, it's part of its role, yes, is to give volume replacement, but at the end of the day, it's more for diluting the oxytocin to run in. On the other hand, it's doing the actual volume replacement. Remember, you can also do 40 international units in a liter. So it doesn't have to be in half a liter. You can double the concentration and put in a liter, although the rate of the oxytocin going in is still about, if you do the 20 units in 500 to run over 250 mL per hour, it means that 10 units of oxytocin are running per hour. You get. So it's about delivering a concentration of oxytocin. The other IV line is about volume replacement. If you're to say you're going to put 20 units in 5 liters, you've overly diluted your oxytocin. So the concentration is still important, while the other line is doing the volume replacement.
Thank you. Someone has commented on the bundle approach. One person has also said the bundle approach has been useful for them. Maybe a comment on the bundle approach.
What do they mean by the bundle approach?
That's a good question.
Yeah, maybe they can share and give us the experience as well.
Let me see who bundled. As I'm looking for the bundle approach fellow, Sabita Kapsabuka says that she thinks it is impossible to manage PPH in a dispensary, bearing in mind that you are alone and you have got no one to shout for help.
Oh, yeah, that is true. It's a challenge, but I think when you get an emergency, you basically do as much as you can with what you have. I'll tell you that sometimes it means getting a non-medic to assist you. I'm not saying it's always the right way to go, but sometimes you need a non-medic, meaning you know you're going to put up a drip. If the watchman is right out there and that is your extra help, call the watchman, point and say, give me that bottle, give me that line. They can become useful because really you just need someone to be able to do 1 or 2 extra things. Yeah, but I think that's also something you should take up with your management. If you're doing deliveries, you should not be doing deliveries alone. Ideally, we should have at least 2 or 3, even in a dispensary level, yeah? So I think that's also a management issue. You can never predict emergencies.
Yeah, I think even when you're in a dispensary, you should actually demand that the dispensary is staffed to the correct staffing levels, that there are availability of things to manage more PPH. In short, what we are saying, if you are conducting any deliveries, then you must be capable of handling emergencies. If not, referral is also a way of management. Thank you very much. I think there are requests for the slides. What we will do, we will send the link out. The presentation is uploaded to the COGS YouTube page. We found that very easy to transmit and repeat so that you can just listen to the presentation over and over again, even at your institution. Are there any more burning questions? Someone can raise their hand by clicking on the raise hand section, and we can take 1 or 2.
I can see someone commenting on the bundle approach. Eh?
Okay.
Yeah, basically it's just a name given to all that we've done, all that is involved in management: massage, oxytocin, IV fluids, examination, escalate. I guess it's just a name that wraps it all up, the bundle approach, from the comments that I see.
Excellent. I have seen someone commenting that there should be a Telegram group. The initial presentation, there was a WhatsApp group for the initial bunch, but now this is almost an open forum. So if you get the link, then you can register and this will be sent to you. We probably do not need WhatsApp or Telegram group, but the Equalize team can take that up and batch all of you into a Telegram group. That's a very good presentation. So Christine Odongo has asked, how do you get the presentation? Look for it in the Kenya Obstetrics and Gynaecological Society YouTube page by the end of tomorrow. And with that, I think we like to maintain this session as short as possible. We want to thank all of you who have attended. And the next will be on Wednesday at 7:30 p.m. as we continue strengthening maternity teams, which is a multidisciplinary approach. And we thank all of you for your participation. Dr. Mwebia, you'd like to comment? I think not. With that, I want to bring the session to a halt and see you, all of you, on Wednesday. You can spread the word because we want as many people capacity build on managing our mothers to prevent maternal morbidity and mortality. Thank you very much.
Thank you too.
Thank you, Dr. Christine. Have a good night, everyone.
All right. Good night.
Good night, you too.
Thank you. Good night.